Hi, in this lecture, we are going to learn about pulmonary circulation, pulmonary edema, and pleural fluid subjects. The topics of our lecture are physiological anatomy of the pulmonary circulatory system first, the pressures in the pulmonary system. The pressures in the pulmonary system are lower than the systemic circulation, I can say. Blood volume of the lungs, how much blood is present in the lungs at a time, and is it possible to uh, give extra blood to the general circulation from the lungs during exercise, for example. Blood flow through the lungs and its distribution. There are different regions of the lungs due to gravity. Effect of hydrostatic pressure gradients in the lungs on regional pulmonary blood flow, and pulmonary capillary dynamics. What are the differences between normal capillaries? And finally, the fluid in the pleural cavity and pleural effusion. The reasons of pleural effusion we are going to learn. The lung has two circulations, a high pressure, low flow circulation, and a low pressure, high flow circulation. A high pressure and low flow circulation supplies the systemic arterial blood to the trachea, the bronchial tree, including the terminal bronchioles, supporting tissues of the lung, and outer coats of the pulmonary arteries and veins. The bronchial arteries, which are branches of the thoracic aorta, supply most of this systemic arterial blood at a pressure that is only slightly lower than the aortic pressure. So, the parenchyma tissue of the lungs themselves need oxygen, nutrients, etc. to survive. Okay, this is for the parenchyma tissue of the lungs itself to survive, not for function. A low pressure, high flow circulation that supplies venous blood from all parts of the body to the alveolar capillaries, where oxygen is added and carbon dioxide is removed. The pulmonary artery, which receives blood from the right ventricle and its arterial branches, carry blood to the alveolar capillaries for gas exchange, and the pulmonary veins then return the blood to the left atrium to be pumped by the left ventricle through the systemic circulation, okay, by aorta. In this lesson, we are going to learn the special aspects of blood flow distribution and other hemodynamics of the pulmonary circulation that are especially important for gas exchange in the lungs. Now, physiological anatomy of the pulmonary circulatory system. Pulmonary vessels. The pulmonary artery extends only 5 centimeters beyond the apex of the right ventricle, and then divides into the right and left main branches that supply blood to the two respective lungs. The pulmonary artery is thin, with a wall thickness of 1/3 that of the aorta. Pulmonary arterial branches are very short, and all the pulmonary arteries, even the smaller arteries and arterioles, have larger diameters than their counterpart systemic arteries. This, combined with the fact that the vessels are thin and distensible, gives the pulmonary arterial tree a large compliance, averaging almost 7 milliliter per millimeter mercury, which is similar to that of the entire systemic arterial tree. This large compliance allows the pulmonary arteries to accommodate the stroke volume output of the right ventricle. The pulmonary veins like the pulmonary arteries, are also short. They immediately empty their effluent blood into the left atrium. Bronchial vessels. Blood also flows to the lungs through small bronchial arteries that originate from the systemic circulation, amounting to about 1 to 2% of the total cardiac output. This bronchial arterial blood is oxygenated blood, in contrast to the partially deoxygenated blood in the pulmonary arteries. It supplies the supporting tissues of the lungs, including the connective tissue, septa, and large and small bronchi. After this bronchial and arterial blood has passed through the supporting tissues, it empties into the pulmonary veins and enters the left atrium, rather than passing back to the right atrium. Therefore, the flow into the left atrium and the left ventricular output are about 1 to 2% greater than that of the right ventricular output. And the percentage of oxygen also goes down a little bit. Here you see the pulmonary arteries and bronchial arteries together. This is a bronchus. As you see, the bronchial artery and the bronchial nerve, they come, as you see here, and provide oxygenated blood to the lung tissue, bronchi, and other parts of the lung to survive, okay? And we also see pulmonary artery here. In this pulmonary artery, there is deoxygenated blood to be oxygenated in the alveoli. So it surrounds the alveoli, and then it will be oxygenated, and then oxygenated blood will go to the left side of the heart, to the left atrium. All right, this is from another textbook from Berne and Levy. Very nice figure, that's why I added it here. But as we see here, the lymphatics are important in the lungs. We are going to learn to prevent the development of edema in the lung alveoli. Lymphatics. Lymph vessels are present in all the supportive tissues of the lung, beginning in the connective tissue spaces that surround the terminal bronchioles, coursing to the hilum of the lung, and then mainly into the right thoracic lymph duct. Particulate matter entering the alveoli is partly removed by way of these channels, and plasma protein leaking from the lung capillaries is also removed from the lung tissues, thereby helping to prevent pulmonary edema. Pressures in the pulmonary system. A pressure pulse curve in the right ventricle. The pressure pulse curves of the right ventricle and pulmonary artery are shown in the figure 39.1. In the upper part, you see the aortic pressure curve, and in the lower part, you see the pulmonary artery curve. As you see, the pressure amount is quite lower compared with the systemic circulation in the pulmonary circulation, okay? It's about 20 millimeter mercury or so, and it is about 100-120 millimeter mercury or so in the systemic circulation. You see here the right ventricular pressure and pulmonary artery pressure. After systole, when it goes to the diastolic phase, the pressure goes down in the right ventricle, whereas it doesn't go that low. Why? Because seminal valves in the orifice of pulmonary artery will be closed and will not let the pressure to go to very low values in the pulmonary artery, okay, in the diastolic phase. These curves are contrasted with much higher aortic pressure curve shown in the upper portion of the figure. The systolic pressure in the right ventricle of the normal human being averages about 25 mm mercury, and the diastolic pressure averages about 0 to 1 mm mercury values that are only one-fifth those for the left ventricle. Okay. Now the pressures in the pulmonary artery. During systole, the pressure in the pulmonary artery is essentially equal to the pressure in the right ventricle, as shown in the figure. However, after the pulmonary valve closes at the end of the systole, ventricular pressure falls precipitously, whereas the pulmonary arterial pressure falls more slowly as blood flows through the capillaries of the lungs. As shown in figure 39.2, the systolic pulmonary arterial pressure averages about 25 mm mercury in the normal human being. The diastolic pulmonary arterial pressure is about 8 mm mercury, and the mean pulmonary arterial pressure is 15 mm mercury. You see here pressures in different levels of the lungs. Red curve shows the arterial pulsations. This is the pulmonary artery, systolic, diastolic, and the mean pressure. As you see, when you go to the capillaries, it becomes smaller, the amplitude, and it arrives to 7 mm mercury in the pulmonary capillaries, and it goes down further in the left atrium. It is estimated to be 2 mm mercury or so. So pulmonary capillary pressure. The mean pulmonary capillary pressure, as diagrammed in figure 39.2, is about 7 mm mercury. The importance of this low capillary pressure will be discussed in detail later in relation to fluid exchange functions of the pulmonary capillaries. Left atrial and pulmonary venous pressures. The mean pressure in the left atrium and the major pulmonary veins averages about 2 mm mercury in the recumbent human being, varying from as low as 1 mm mercury to as high as 5 mm mercury. It usually is not feasible to measure a human being's left atrial pressure using a direct measuring device because it is difficult to pass a catheter through the heart chambers into the left atrium. However, the left atrial pressure can often be estimated with moderate accuracy by measuring the so-called pulmonary wedge pressure. This is achieved by inserting a catheter first through a peripheral vein to the right atrium, then through the right side of the heart and through the pulmonary artery into one of the small branches of the pulmonary artery, finally pushing the catheter until it wedges tightly in the small branch. It doesn't go further. The pressure measured through the catheter called the wedge pressure. It is about 5 mm mercury because all blood flow has been stopped in the small wedged artery and because the blood vessels extending beyond this artery make a direct connection with the pulmonary capillaries. This wedge pressure is usually only 2 to 3 mm mercury higher than the left atrial pressure. When the left atrial pressure rises to high values, the pulmonary wedge pressure also increases. Therefore, wedge pressure measurements can be used to clinically study the changes in pulmonary capillary pressure and the left atrial pressure in patients with congestive heart failure. Now the blood volume of the lungs. The blood volume of the lungs is about 450 milliliters, about 9% of the total volume of entire circulatory system. Approximately 70 milliliters of this pulmonary blood volume is in the pulmonary capillaries. and the remainder is divided about equally between the pulmonary arteries and veins. The lungs serve as a blood reservoir. Under various physiological and pathological conditions, the quantity of blood in the lungs can vary from as little as one half normal up to twice normal. For instance, when a person blows out air so hard that high pressure is built up in the lungs, such as when blowing a trumpet, as much as 250 milliliters of blood can be expelled from the pulmonary circulation system to the systemic circulation system. Also, loss of blood from the systemic circulation by hemorrhage can be partly compensated for by the automatic shift of blood from the lungs into the systemic vessels. Cardiac pathology may shift blood from the systemic circulation to the pulmonary circulation. Failure of the left side of the heart or increased resistance to blood flow through the mitral valve as a result of mitral stenosis or mitral regurgitation causes blood to dam up in the pulmonary circulation, sometimes increasing the pulmonary blood volume as much as 100% and causing large increases in pulmonary vascular pressures. Because the volume of the systemic circulation is about 9 times that of the pulmonary system, a shift of blood from one system to the other affects the pulmonary system greatly, but usually has only mild systemic circulatory effects. Blood flow through the lungs and its distribution. Blood flow through the lungs is essentially equal to the cardiac output. Therefore, the factors that control cardiac output, mainly peripheral factors, also control pulmonary blood flow. Under most conditions, the pulmonary vessels act as passive, distensible tubes that enlarge with increasing pressure and narrow with decreasing pressure. For adequate aeration of the blood to occur, it is important for the blood to be distributed to those segments of the lungs where alveoli are best oxygenated. This is achieved by following mechanism. Decreased alveolar oxygen reduces local alveolar blood flow and regulates pulmonary blood flow distribution. When the concentration of oxygen in the air of the alveoli decreases below normal, especially when it falls below 70% of normal, below 73 mm mercury oxygen partial pressure, the adjacent blood vessels constrict, with the vascular resistance increasing more than fivefold at extremely low oxygen levels. Let's see the figure. Here, in the upper part of this figure, you see the aeration is good and perfusion is good. So ventilation and perfusion is good. In the lower part of this figure, as you see, oxygen level goes up in this. So aeration goes down, and then vasoconstriction occurs in this one. On the other hand, this one has increased aeration and perfusion also. So the regulation of blood flow in lungs during local tissue hypoxia. Local tissue blood flow and alveolar ventilation are normally matched for optimal gas exchange. In the top panel, we see ventilation and perfusion is good, matched. On the other hand, decreased oxygen partial pressure in tissue surrounding poorly ventilated alveoli causes vasoconstriction of adjacent arterioles and diverts blood flow to alveoli that are well ventilated. Let's say there is a tumor in this part of the bronchi, so preventing the airflow coming to this alveoli. So there will be hypoxia in this alveoli due to continuous diffusion of oxygen to the blood, and no new fresh air coming, so there will be hypoxia development, and then it will cause vasoconstriction in the blood vessels coming to this alveoli, to this part of the lungs. So it will be directed to the other well aerated alveoli. Okay, so this is opposite to the effect observed in systemic vessels, which dilate rather than constrict in response to low oxygen. Uh, Remember, in systemic circulation, when there is hypoxia in a tissue, it was one of the local factors causing vasodilation, so that increasing the blood flow to that tissue. On the other hand, here in the lungs, when oxygen level goes down in the alveoli, it causes vasoconstriction in the blood vessels coming to that alveoli, so that preventing uh, arteriovenous shunt. So it prevents the venous blood to go to the left side of the heart without oxygenation. So although the mechanisms that promote pulmonary vasoconstriction during hypoxia are not completely understood, low oxygen concentration may have the following effects. So low oxygen in the alveoli can stimulate the release of or increase the sensitivity to vasoconstrictor substances such as endothelin or reactive oxygen species, or low oxygen in alveoli can decrease the release of a vasodilator such as nitric oxide from the lung tissue. Some studies have suggested that hypoxia may directly induce vasoconstriction by inhibition of oxygen-sensitive potassium ion channels in the pulmonary vascular smooth muscle cell membranes. With low partial pressures of oxygen, these channels are blocked, leading to depolarization of the cell membrane and activation of calcium channels and causing the influx of calcium ions. The rise of calcium concentration then causes constriction of the small arteries and arterioles in this part of the lung, in the hypoxic part. The increase in pulmonary vascular resistance as a result of low oxygen concentration has important function of distributing blood flow where it is most effective. That is, if some alveoli are poorly ventilated so that their oxygen concentration becomes low, the local vessels going to those alveoli will be constricted. This causes the blood flow through other areas of the lungs that are better aerated, thus providing an automatic control system for distributing blood flow to the pulmonary areas in proportion to their alveolar oxygen pressures. It helps the blood to be oxygenated well. It prevents arteriovenous shunt. Effect of hydrostatic pressure gradients in the lungs on regional pulmonary blood flow. Blood pressure in the foot of a standing person can be as much as 90 mmHg greater than the pressure at the level of the heart. This is caused by hydrostatic pressure, that is, by the weight of the blood itself in the blood vessels. The same effect, but to a lesser degree, occurs in the lungs. In the normal, upright adult, the lowest point in the lungs is about 30 cm below the highest point. This represents a 23 mmHg pressure difference, about 15 mmHg of which is above the heart and 8 mmHg below the heart. That is, the pulmonary arterial pressure in the uppermost portion of the lung of a standing person is about 15 mmHg less than the pulmonary arterial pressure at the level of the heart, and the pressure in the lowest portion of the lung is about 8 mmHg greater. Such pressure differences have profound effects on blood flow through the different areas of the lungs. This is demonstrated by the lower curve in figure 39.4, which depicts blood flow per unit of lung tissue at different levels of the lung in the upright person. Okay, this is lung level, top of the lungs, middle part, and the bottom. As you see in the standing at rest, the highest amount of blood flow is present in the bottom, and mild amount, moderate amount in the middle of the lung, and then the lowest amount of blood flow is on top, in the apex part of the lungs. Blood flow at different levels in the lung of an upright person at rest and during exercise. Note that when the person is at rest, the blood flow is very low at the top of the lungs. Most of the flow is through the bottom of the lung. Yes. Note that in the standing position at rest, there is little flow in top of the lung, but about 5 times as much flow in the bottom of the lung. To help explain these differences, one often describes the lung as being divided into 3 zones, as shown in figure 39.5. In each zone, the patterns of blood flow are quite different. So, in this figure, you see the zones in the lung. This is the apex part, and then this is the bottom, basal part of the lung, you can think. And actually, we don't see zone 1 type in normal healthy person. So in zone 1, there is no blood flow in both systole and diastole of the cardiac cycle, systolic or diastolic phases of the cardiac cycle. Always the pressure inside of the alveoli overcomes, so the blood cannot move from the arterial side to the venous side. On the other hand, in zone 2, by each systole, only during systolic phase of the cardiac cycle, the blood can move to the other side. Okay, so the blood can be oxygenated from time to time, not in the diastolic phase, but only during systolic phase. And in zone 2, on the other hand, capillaries, pulmonary capillaries are always open. So in both systolic and diastolic phases of the cardiac cycle, blood will be oxygenated and blood will flow smoothly, continuously. Okay? So, zone 1, 2, and 3 of pulmonary blood flow. The capillaries in the alveolar walls are distended by the blood pressure inside of them, but simultaneously they are compressed by the alveolar air pressure on their outsides. Therefore, anytime the lung alveolar air pressure becomes greater than the capillary blood pressure, the capillaries will be closed and there will be no blood flow. Under different normal and pathological lung conditions, one may find any one of 3 possible zones of the pulmonary blood flow as follows. Zone 1. No blood flow during all portions of the cardiac cycle because local alveolar capillary pressure in that area of the lung never rises higher than the alveolar air pressure during any part of the cardiac cycle. Zone 2. Intermittent blood flow only during the peaks of pulmonary arterial pressure because the systolic pressure is then greater than the alveolar air pressure, but the diastolic pressure is less than the alveolar air pressure. So only systolic phases of the cardiac cycle, the blood will flow. In zone 3, on the other hand, continuous blood flow because the alveolar capillary pressure remains greater than alveolar air pressure during the entire cardiac cycle in both systole and diastole. Normally, the lungs have only zones 2 and 3 blood flow zones in the, uh, in the apices and zone 3 at the lower areas. So normally we don't have zone 1 in the normal healthy lungs. For example, when a person is in the upright position, the pulmonary arterial pressure at the lung apex is about 15 mm mercury less than the pressure at the level of the heart. Therefore, the apical systolic pressure is only 10 mm mercury, 25 mm mercury at the heart level minus 15 mm mercury hydrostatic pressure difference. This 10 mm mercury apical blood pressure is greater than the zero alveolar air pressure, so blood flows through the pulmonary apical capillaries during cardiac systole. Conversely, during diastole, the 8 mm mercury diastolic pressure at the level of the heart is not sufficient to push the blood up the 15 mm mercury hydrostatic pressure gradient required to cause diastolic capillary flow. Therefore, blood flow through the apical part of the lung is intermittent, with flow during systole but cessation of flow during diastole. This is called zone 2 blood flow. Zone 2 blood flow begins in the normal lungs about 10 cm above the mid-level of the heart and extends from there to the top of the lungs. In the lower regions of the lungs, from about 10 cm above the level of the heart all the way to the bottom of the lungs, the pulmonary arterial pressure during both systole and diastole remains greater than the zero alveolar air pressure. Therefore, there is continuous flow through the alveolar capillaries or zone 3 blood flow. Also, when a person is lying down, no part of the lung is more than a few centimeters above the level of the heart. In this case, blood flow in normal person is entirely zone 3 blood flow, including the lung apices. Zone 1 blood flow occurs only under abnormal conditions. Zone 1 blood flow, which means no blood flow at any time during the cardiac cycle, occurs when either the pulmonary systolic arterial pressure is too low or the alveolar pressure is too high to allow the flow. For instance, if an upright person is breathing against a positive air pressure so that the intra-alveolar air pressure is at least 10 mm mercury greater than normal, but the pulmonary systolic blood pressure is normal, one would expect zone 1 blood flow, no blood flow in the lung apices. Another instance in which zone 1 blood flow occurs is in an upright person whose pulmonary systolic arterial pressure is exceedingly low, as might occur after severe blood loss. Effect of exercise on blood flow through the different parts of the lungs. Referring again to figure 39.4, one sees that the blood flow in all parts of the lung increases during exercise. The increase in flow in top of the lung may be 700 to 800%, whereas the increase in the lower part of the lung may be no more than 200 to 300%. The reason for these differences is that the pulmonary vascular pressures rise enough during exercise to convert the lung apices from a zone 2 pattern into a zone 3 pattern of flow. So, during exercise, you see in every part, every level of the lung, there is huge amount of blood flow. Again, it is higher in the bottom, but it is higher in everywhere. It is high very high in every part of the lungs. On top part, apex part of the lung, the middle part, and the bottom parts. During exercise, everywhere, every part of the lung will have zone 3 blood zone, flow zone, okay? Increased cardiac output during heavy exercise is normally accommodated by the pulmonary circulation without large increases in pulmonary arterial pressure. During heavy exercise, blood flow through the lungs increases 4 times to 7 times. This extra flow is accommodated in the lungs in 3 ways. First, by increasing the number of open capillaries, sometimes as much as threefold. And the second, by distending all the capillaries and increasing the rate of flow through each capillary more than 2 times. And the third, by increasing the pulmonary arterial pressure. In the normal person, the first 2 changes decrease pulmonary vascular resistance so much that the pulmonary arterial pressure rises very little even during maximum exercise. This effect is shown in figure 39.6. So here you see the cardiac output. Normally it is about 5 liters, and during exercise it increases sometimes to 4 times, 5 times, as you see. Although the cardiac output increases 4 times, it becomes 20 liters per minute during heavy exercise. As you see, the pulmonary arterial pressure does not increase that much, although it is 4 times increased cardiac output. It increases a little bit, let's say from 17 or 16 to 25 or so. The ability of the lungs to accommodate greatly increased blood flow during exercise without increasing the pulmonary arterial pressure much conserves the energy of the right side of the heart. This ability also prevents a significant rise in pulmonary capillary pressure, thus also preventing the development of pulmonary edema. Function of the pulmonary circulation when the left atrial pressure rises as a result of left-sided heart failure. Left atrial pressure in a healthy person almost never rises above 6 mm mercury, even during the most strenuous exercise. These small changes in the left atrial pressure have virtually no effect on pulmonary circulatory function, because this merely expands the pulmonary venules and opens up more capillaries so that blood continues to flow with almost equal ease from the pulmonary arteries. When the left side of the heart fails, however, blood begins to dam up in the left atrium. As a result, left atrial pressure can rise on occasion from its normal value of 1 to 5 mm mercury all the way up to 40 to 50 mm mercury. The initial rise in atrial pressure up to about 7 mm mercury has very little effect on pulmonary circulatory function. But when the left atrial pressure rises to greater than 7 or 8 mm mercury, further increases in left atrial pressure above these values cause almost equally great increases in pulmonary arterial pressure, thus causing a concomitant increased load on the right heart. Any increase in the left atrial pressure above 7 or 8 mm mercury increases the capillary pressure almost equally as much. When the left atrial pressure has risen above 30 mm mercury, causing similar increases in capillary pressure, pulmonary edema is likely to develop, as we are going to discuss later. Now, pulmonary capillary dynamics. Exchange of gases between the alveolar air and pulmonary capillary blood is not discussed here. However, it is important to note here that the alveolar walls are lined with so many capillaries that in most places the capillaries almost touch one another side by side. Therefore, it is often said that the capillary blood flows in the alveolar walls as a sheet of flow rather than in individual capillaries. Pulmonary capillary pressure. Although direct measurements of pulmonary capillary pressure have not been reported, indirect estimates have suggested that it normally averages about 7 mm mercury. This is probably nearly correct because the mean left atrial pressure is about 2 mm mercury, and then the mean pulmonary arterial pressure is only 15 mm mercury. So the mean pulmonary capillary pressure must lie somewhere between these two values. Length of time blood stays in the pulmonary capillaries. From histological study of the total cross-sectional area of all the pulmonary capillaries, it can be calculated that when the cardiac output is normal, blood passes through the pulmonary capillaries in about 0.8 seconds. When the cardiac output increases, this can be shortened as little as 0.3 seconds. The shortening would be much greater were it not for the fact that additional capillaries, which normally are collapsed, open up to accommodate the increased blood flow. Thus, in only a fraction of a second, blood passing through the alveolar capillaries becomes oxygenated, loses its excess carbon dioxide. Capillary exchange of fluid in the lungs and pulmonary interstitial fluid dynamics. The dynamics of fluid exchange across the lung capillary membranes are qualitatively the same as for peripheral tissues. However, quantitatively, there are important differences as follows. First, the pulmonary capillary pressure is low, about 7 mm mercury, in comparison with a considerably higher functional capillary pressure in the peripheral tissues of about 17 mm mercury. And the second, the interstitial fluid pressure in the lung is slightly more negative than that in the peripheral subcutaneous tissue. This has been measured in two ways: by a micropipette inserted into the pulmonary interstitium, giving a value of about -5 mm mercury, and by measuring the absorption pressure of fluid from the alveoli, giving a value of about -8 mm mercury. And the third, pulmonary capillaries are relatively leaky to protein molecules. So the colloid osmotic pressure of the pulmonary interstitial fluid is about 14 mm mercury in comparison with less than half this value in the peripheral tissues. And the fourth, alveolar walls are extremely thin, and the alveolar epithelium covering the alveolar surfaces is so weak that it can be ruptured by any positive pressure in the interstitial spaces greater than alveolar air pressure over 0 mm mercury, which allows dumping of fluid from the interstitial spaces into the alveoli. Now let us see how these quantitative differences affect pulmonary fluid dynamics. Interrelations between interstitial fluid pressure and other pressures in the lung. Figure 39.7 shows a pulmonary capillary, a pulmonary alveolus, and a lymphatic capillary draining the interstitial space between blood capillary and the alveolus. Note that the balance of forces at the blood capillary membrane as follows. Okay, so this figure shows hydrostatic and osmotic forces in millimeter mercury at the capillary on the left hand side and alveolar membrane on the right hand side of the lungs. Also shown is the tip end of a lymphatic vessel in the center that pumps fluid from the pulmonary interstitial spaces. So, in pulmonary artery, there is blood, proteins, osmotic, which produces 28 millimeter mercury sucking pressure, so keeping fluid inside of the pulmonary capillary, and hydrostatic pressure +7. So again, colloid osmotic pressure due to leaking proteins in the interstitium is quite high, 14 millimeter mercury, and in the interstitium it is about -8 hydrostatic pressure. So on the surface it is -8, then it is due to there is a zero net pressure here is +1 in the arterial part. So if you add if you calculate the forces towards interstitium or from the interstitium into the capillary, we will see in the table. Let's see the table. So in the capillary pressure it is 7, interstitial fluid colloid osmotic pressure 14, and negative interstitial pressure 8. So -8. So it is 29 millimeter mercury towards outside of the blood vessel, and the forces tending to cause absorption of fluid into the capillaries, plasma colloid osmotic pressure only, and it is 28. So the difference is +1. So by +1, thus the normal outward forces are slightly greater than the inward forces, providing a mean filtration pressure at the pulmonary capillary membrane that can be calculated as 1 millimeter mercury. This filtration pressure causes a slight continual flow of fluid from the pulmonary capillaries into the interstitial spaces, and except for a small amount that evaporates in the alveoli, this fluid is pumped back into the circulation through the pulmonary lymphatic system. Okay, so when we look at here, you can see the forces taking part: osmotic pressure, hydrostatic pressure, so altogether 29 towards outside, and then so this will cause fluid leakage into the interstitium all the time, and then this excess fluid leaking into the interstitium, some of it will be evaporated from the alveoli, and the rest will be removed away by lymphatic pump of the lung tissue interstitium. Okay. Negative pulmonary interstitial pressure and the mechanism for keeping the alveoli dry. What keeps the alveoli from filling with fluid under normal conditions? The pulmonary capillaries and pulmonary lymphatic system normally maintain a slight negative pressure in the interstitial spaces. Whenever extra fluid appears in the alveoli, it is sucked mechanically into the lung interstitium through the small openings between the alveolar epithelial cells. The excess fluid is then carried away through the pulmonary lymphatics. Thus, under normal conditions, the alveoli are kept dry, except for a small amount of fluid that seeps from the epithelium onto the lining surfaces of the alveoli to keep them moist, to keep them wet. Pulmonary edema. Pulmonary edema occurs in the same way that edema occurs elsewhere in the body. Any factor that increases fluid filtration out of the pulmonary capillaries, or that impedes pulmonary lymphatic function and causes the pulmonary interstitial fluid pressure to rise from the negative range into the positive range, will cause rapid filling of the pulmonary interstitial spaces and alveoli with large amounts of free fluid. The most common causes of pulmonary edema are as follows. First, left-sided heart failure or mitral valve disease with consequent great increases in pulmonary venous pressure and pulmonary capillary pressure and flooding of the interstitial spaces and alveoli. And the second, damage to the pulmonary blood capillary membranes caused by infections such as pneumonia or by breathing noxious substances such as chlorine gas or sulfur dioxide gas. Each of these mechanisms causes rapid leakage of both plasma proteins and fluid out of the capillaries and into both the lung interstitial spaces and the alveoli. Pulmonary edema safety factor. Experiments in animals have shown that the pulmonary capillary pressure normally must rise to a value at least equal to the colloid osmotic pressure of the plasma inside the capillaries before significant pulmonary edema to occur. To give an example, figure 39.8 shows how different levels of left atrial pressure increase the rate of pulmonary edema formation in dogs. Okay, here. So the rate of fluid loss into the lung tissues when the left atrial pressure is increased and also pulmonary capillary pressure. So it is normally left atrial pressure is about 0 or something. As you see, until 2023, there is no pulmonary edema formation. After this point, now fluid leaks into the alveoli and then pulmonary edema will be formed, will develop. Remember that every time the left atrial pressure rises to high values, the pulmonary capillary pressure rises to a level 1 to 2 mm greater than the left atrial pressure. In these experiments, as soon as the left atrial pressure rose above 23 mm mercury, causing the pulmonary capillary pressure to rise above 25 mm mercury, fluid began to accumulate in the lungs. This fluid accumulation increased even more rapidly with further increases in capillary pressure. The plasma colloid osmotic pressure during these experiments was equal to this 25 mm mercury critical pressure level. Therefore, in a person whose normal plasma colloid osmotic pressure is 28 mm mercury, one can predict that the pulmonary capillary pressure must rise from the normal level of 7 mm mercury to more than 28 mm mercury to cause pulmonary edema, giving an acute safety factor against pulmonary edema of 25 mm mercury. So it's not easy to develop pulmonary edema. Safety factor in chronic conditions. When the pulmonary capillary pressure remains elevated chronically for at least 2 weeks, for example, the lungs become even more resistant to pulmonary edema because the lymph vessels expand greatly, increasing their capability of carrying fluid away from the interstitial spaces perhaps as much as 10 times. Therefore, in patients with chronic mitral stenosis, pulmonary capillary pressures of 40 to 45 mm mercury have been measured without development of lethal pulmonary edema. Rapidity of death in acute pulmonary edema. When the pulmonary capillary pressure rises even slightly above the safety factor level, lethal pulmonary edema can occur within hours, or even within 20 to 30 minutes if the capillary pressure rises 25 to 30 mm mercury above the safety factor level. Thus, in acute left-sided heart failure, in which the pulmonary capillary pressure occasionally does rise to 50 mm mercury, death frequently ensues in less than 30 minutes from acute pulmonary edema. So left-sided heart failure generally follows the myocardial infarction. Okay. Now finally, the last part of our lecture, fluid in the pleural cavity. When the lungs expand and contract during normal breathing, they slide back and forth within the pleural cavity. To facilitate this, a thin layer of mucoid fluid lies between the parietal and visceral pleurae. Figure 39.9 shows the dynamics of fluid exchange in the pleural space. Okay, you see here, this is the parietal pleura, and then this is we don't see here parietal pleura. This is visceral pleura covering the lung, okay? And the parietal pleura is covering the chest wall to the opposite, and there is a mucous secretion, the pleural fluid here. Blood is oxygenated and going back to the heart. So by pulmonary arteries, the oxygenated blood comes, and then oxygenated blood returns to the left ventricle. Left atrium. Okay, from both lungs. What else we see here? The lymphatics. Lymphatics, they drain, they remove the pleural fluid, and then finally take it to the venous blood circulation. The pleural membrane is a porous, mesenchymal, serous membrane through which small amounts of interstitial fluid transute continually into the pleural space. These fluids carry with them tissue proteins, giving the pleural fluid a mucoid characteristics, which is what allows extremely easy slippage of the moving lungs during inspiration and expiration. The total amount of fluid in each pleural cavity is normally slight, only a few millimeters. Whenever the quantity becomes more than barely enough to begin flowing in the pleural cavity, the excess fluid is pumped away by lymphatic vessels opening directly from the pleural cavity into the mediastinum, the superior surface of the diaphragm, and lateral surfaces of the parietal pleura. Therefore, the pleural space, the space between the parietal and visceral pleura, is called as a potential space because it normally is so narrow that it is not obviously a physical space at all. Negative pressure in pleural fluid. A negative force is always required on the outside of the lungs to keep the lungs expanded. This is provided by negative pressure in the normal pleural space. The basic cause of this negative pressure is pumping of fluid from the space by the lymphatics, which is also the basis of negative pressure found in most tissue spaces of the body. Because the normal collapse tendency of the lungs is about 4 mm mercury, the pleural fluid pressure must always be at least as negative as minus 4 mm mercury to keep the lungs expanded. Actual measurements have shown that the pressure is usually about minus 7 mm mercury, which is a few millimeters of mercury more negative than the collapse pressure of the lungs. Thus, the negativity of the pleural fluid keeps the normal lungs pulled against the parietal pleura of the chest cavity, except for an extremely thin layer of mucoid fluid that acts as a lubricant. Now finally, pleural effusion, collection of large amounts of free fluid in the pleural space. Pleural effusion is analog to edema fluid in the tissues and can be called as edema of the pleural cavity. The causes of the effusion are the same as the causes of edema in other tissues, including blockage of lymphatic drainage from the pleural cavity, cardiac failure, which causes excessively high peripheral and pulmonary capillary pressures leading to excessive transudation of fluid into the pleural cavity. And as the third reason, greatly reduced plasma colloid osmotic pressure, thus allowing excessive transudation of fluid. And finally, fourth reason of pleural effusion is infection or any other cause of inflammation of the surfaces of the pleural cavity, which breaks down the capillary membranes and allows rapid dumping of both plasma proteins and fluid into the cavity. So today we have learned about pulmonary circulation. If I try to summarize the subject, there are two blood flow in the lungs. One of them has high blood pressure and low amount. It is bronchial arterial circulation, providing oxygen and nutrients to the lung tissue itself. And the second one is high flow, low pressure. It comes from the heart, from the right side of the heart. Okay, it is deoxygenated blood. Uh, the reason it comes to the lungs is to be oxygenation. Uh, okay, the bronchial arterial tree, the venous part of it, will drain into the left side of the heart, to the left ventricle directly, so it mixes the blood. So oxygenated blood comes from the left side, from the pulmonary veins to the ventricle. The oxygenation percentage will go down a little bit. This is mixing of the venous lung tissue blood, the reason of it. Okay. Uh, the second important point about pulmonary circulation is the pressures in the lung tissue. In pulmonary circulation, in the systemic circulation, in the aorta, the pressures are very high, 120 millimeter mercury systolic and 80 millimeter mercury diastolic. On the other hand, the pressures, pulse pressure contours are very low, about 20 millimeter mercury around. Okay, so it is 5 times less in pulmonary circulation. What else we have to keep in mind about the lung circulation is zones. Okay, due to gravity, uh, the blood flows very well in the basal parts of the lungs, and then these capillaries are always open during both systolic and diastolic phases. So there is zone 3 blood flow in the basal sides of the lungs, and then zone 2 blood flow in the apex part of the lungs, uh, opening just during systolic phase of the cardiac cycle. We don't have zone 1 blood flow zones normally, okay? In a normal lung, we don't have. We can have zone 1. It means there is no blood flow during both systolic and diastolic phases of the cardiac cycle when we have hypovolemia, okay? During hypovolemia conditions, then we can have a zone 1 in the apex part of the lungs. Another point about pulmonary circulation is that uh, in local control of blood flow, when there is hypoxia in the blood, in that tissue, there will be vasodilation to bring more oxygen to that tissue. Here in the lungs, if there is a problem with aeration of an alveole, so there will be hypoxia in that alveole. In this case, there will be vasoconstriction in the blood vessel, in the blood capillary coming to that alveole. Okay? So that it prevents the blood to enter, to go from right side of the heart to the left side of the heart. We call it as shunt So this prevents shunt, okay? This does not let the blood to go to the other side of to the left side of the heart without oxygenation. It is a good. And during exercise, all blood vessels will be opened, and everywhere in the lungs will be blood circulation will be active. All capillaries will be open, and then all parts of the lungs will have zone 3 blood circulation. In capillary dynamics point of view, I think pulmonary circulation is unique. 14 millimeter mercury osmotic pressure is present in the interstitium of the lungs. It is very, very high compared with normal capillaries. Okay, it is minus 8 millimeter mercury interstitial pressure, and it is just 7 millimeter mercury in the pulmonary capillary. So 7 plus minus 8 plus 14, so altogether 29, and then there is only 28 inside of the blood vessel due to osmotic pressure of proteins, and then by 1 millimeter mercury it goes out of the capillaries. There is a fluid leakage into the interstitium, and then some of the fluid is evaporated from the alveoli when we are breathing. If somehow some fluid is collected inside of the alveoli, and will be sucked into the interstitium, and then it will be removed by lymphatics. Okay, lymphatics. There is here about 21 millimeter mercury safety factor to prevent edema. Still, in left-sided heart failure of acute heart failure due to myocardial infarction, it causes a sudden increase in the capillary hydrostatic pressure of the pulmonary circulation, because left side of the heart is not able to pump the blood coming from the lungs. Then the pressure inside of the lung capillaries will be increased quite much. It can increase to 50 millimeter mercury values, very high, and then it will cause fluid leakage into the alveoli, and then it is very, very dangerous situation, and then the person will be drowned in his blood, we can say, and then in 30 minutes he can die. Okay. Finally, we have talked about pleural cavity, pleural space, and pleural effusion. Here there are parietal and visceral pleura sliding each other. There is protein-rich fluid, pleural fluid there, and then this fluid is a transsuda, and then it is removed continuously by lymphatic blood vessels, lymphatic vessels. Somehow it can be increased, the amount can be increased, and this is pleural edema. This is pleural cavity, pleural effusion. The reasons may be left-sided heart failure, protein concentration goes down in the blood, decreased osmotic pressure, and the infection, I guess. The infection, there may be an infection. So these can cause pleural effusion, increased fluid in the pleural cavity. That's all. I hope you can understand the subject. Thank you very much for listening.